Good morning. So I'm going to do a year in review of anesthesia and surgical critical care. I have no relevant financial disclosures, but it should be noted that I believe ECMO works, so take everything I say with a grain of salt. Just to review quickly, in 2018 to 2019, NIH spending was $39.2 billion. There were 2.5 million scientific articles published, and I have 20 minutes, so strap in. I tried to condense it as much as possible. Nothing works, nothing we do matters, and more research is needed. So I'll take any questions. All right, let's go through with the case presentation. So Mr. Smith is a 65-year-old gentleman, history of obesity, hypertension, diabetes, the usual. Comes in for an elective AAA repair. And he tells you that his brother recently had something similar done, and he had a bad bout of ICU delirium. And he's worried the same thing will happen to him. So as we've just heard, which of these drugs is effective in treating delirium? Ziprasidone, Haldol, Midaz, rocuronium, nothing works, nothing we do matters. Rock is my treatment of choice for delirium. Yes, nothing works and nothing we do matters. I agree. So this brings us to the question of, if we can't treat delirium, as we just heard, maybe we can do something to prevent it. So we're going to go through two quick trials here. The first is the Engages trial out of Michael Avedon's group at WashU, using EEG-guided anesthetic to look at postoperative delirium among older adults. So they looked at older adults because they're at higher risk for delirium, and then they randomized them to either EEG-driven anesthetic care or standard of care, where we just kind of look at a number and make it up as we go. So this is anesthesia for the non-anesthesiologists. BIS, many of us are familiar with in the ICU. It's a proprietary algorithm that integrates EEG tracings and then spits out a random number. Less than 60, you're probably unconscious. Less than 40, you probably have way too much anesthetic on board. And then MAC is the minimum alveolar concentration of an anesthetic gas. Higher MAC means more gas, which means you're a deeper anesthetic. And this is the standard of care that we usually use on all of our anesthesia machines to monitor anesthesia. So for this trial, they randomized you to either EEG or standard of care, where you just look at the MAC number and hope you're in a good place. They put a BIS on everyone. And then in the EEG-guided group, clinicians had access to the BIS value and the bifrontal tracing. And in addition to that, a research group would actually look at all the data together and give you real-time feedback on what they thought you should do with your management. So this is just an example they give in the paper. This is an anesthesia monitor with the EEG tracing displayed there in the sort of golden rod in the middle. And this is their example of feedback they would give. So if you're looking at the EEG tracing, there's delta spindles, but then you see probably a little bit of burst suppression down here. So taken all together, they said that this is probably too deep of an anesthetic. So as part of this study, the anesthesia team would be advised to cut back on the amount of anesthetic drug they're giving. So it turns out that the EEG group did, in fact, receive less anesthetic gas. The EEG group spent less time in burst suppression, which means that we weren't completely shutting down the brain. And the EEG group had less time with BIS values less than 40, meaning that these patients were probably not being overdosed on anesthesia as much as the other folks were. Unfortunately, less anesthetic did not equal less delirium. The p-value was 0.2. There was no difference between the two groups. Did not change the duration of delirium, the severity of delirium, or the time to onset of delirium. Less anesthesia does equal more moving. So for those of you who are surgeons or anesthesiologists, you can imagine that led to a lot of yelling in the operating room. Now, the really interesting thing about this is that the study was not powered to detect a mortality difference, but they found one anyway. So this is probably a result of the study just being too small, and this is probably a type 2 error, maybe. but there was actually less mortality in the EEG guided group than in the standard of care group. So it's really hard to draw conclusions from this, but I think what we can say is EEG monitoring leads to less use of anesthetic gas. Unfortunately, less anesthetic gas does not equal less delirium. It does lead to more intraoperative movement, and for some reason it was actually associated with less death. So I think that this is something that needs to be looked into, especially as we understand more and more about the immunomodulatory effects of anesthetics, but it's really hard to draw conclusions from this paper, aside from nothing works and nothing we do matters. So Mr. Smith had his surgery without a BIS monitor and presents to your ICU still intubated. So what can you do to reduce his chances of delirium? Add more midazolam, schedule haloperidol, paralyze him, an overnight infusion of dexmedetomidine combined with a reduction in other anesthetics. That's a weirdly specific answer. And nothing works, nothing we do matters. All right. The rational test takers and the pessimists are about evenly balanced in this group. So the answer here is an overnight infusion of dexmedetomidine combined with a reduction in other anesthetics. So this was a very small trial published in Critical Care looking at a low-dose nocturnal dexmedetomidine infusion for the prevention, not treatment, but prevention of ICU delirium. So it was adult patients admitted to a MICU and a mixed med-surg unit in 2 different centers who were, for some reason, receiving a continuous infusion of sedatives, and it excluded patients who were already delirious based on the intensive care delirium screening checklist. So their intervention every night from 9:30 p.m. to 6 a.m., they got a dexmedetomidine infusion or a placebo infusion. It was targeted to a RASS of -1. They had a titration range. All other sedatives were cut in half. And then, as needed, you could add midazolam for agitation in a non-blinded fashion. And this was continued from the day of randomization until they were discharged from the ICU, whenever that happened to be. So there was a small study, only 50 patients in each arm. The DEX group required less propofol, which is not surprising. If you're receiving dexmedetomidine, you will probably be more sedated than if you're receiving a placebo. And interestingly, if you looked at the number of delirious patients, or the number of patients without delirium, rather, the dexmedetomidine group performed much better than the placebo group. Interestingly, it was pretty similar at first, but throughout the course of their ICU stay, the dexmedetomidine group continued to do slightly better. And if you look at the number of patients who were delirious on any given day, you can see the placebo group had a lot more delirium than the dexmedetomidine group. So what I took away from this study is that dexmedetomidine combined with a reduction in all your other sedatives may reduce the incidence of delirium. It's a relatively small pilot study, more data is needed. What's really unclear to me from reading this is it because dexmedetomidine magically, corrects your sleep-wake cycles and you get the theta wave sleep that's supposed to be good and blah, blah, blah? Or is it just that they cut everyone's midazolam infusion in half and therefore they got a lot less delirious? It's hard for me to say one way or another, but it's an interesting concept. Did I screw that up? No. All right, it's messing with my head. So Mr. Smith continues to have worsening oxygenation overnight. His latest ABG is 7.30, 5260. His ventilator is set to a PEEP of 12 and FiO2 of 100%. We're doing good lung protective ventilation with 6 cc's per kilo. What else can we do to optimize his vent? We can place an esophageal balloon to optimize PEEP. We can titrate PEEP based on the table from the failed Oscillate trial. Nothing going above a PEEP of 12 could cause more harm than good. Or we could call palliative care because nothing works and nothing we do matters. of esophageal balloon believers? So the answer is actually B, titrate the PEEP based on the table from the failed Oscillate trial. So the initial excitement for esophageal balloons came from the EP vent study from Danny Talmore's group up in Boston. So it was followed up by the EP Vent 2 study, which was recently published in JAMA. And he is a great scientist, and he's really bad at coming up with paper titles, so I'm not even going to read that. So what he did is he randomized adult patients with moderate to severe ARDS, meaning the P-to-F ratio less than 200, to either esophageal balloon-driven management or empiric PEEP management. So the interventions here, all patients received a recruitment maneuver so that everyone was sort of starting from the same place. The esophageal manometry guided PEEP group was titrated to achieve a transpulmonary pressure of greater than or equal to 0, which we'll talk about a little on the next slide. And the empiric PEEP arm was titrated based on the PEEP table from the Oscillate trial. And just to refresh your memory, it was about 5 years, longer than that now, 7 years ago, the Oscillate trial showed that an oscillating ventilator was inferior to a high PEEP table. And one of the recruitments, or one of the criticisms of the initial EP vent study looking at the sorry, I'm struggling this morning. One of the criticisms of the EP Vent 2 study was that the control arm did not use very much PEEP. So this was the table from the updated study, where you can see the FiO2 here on the left. And as you require higher and higher FiO2s, you either titrate your transpulmonary pressure as measured by the esophageal balloon, meaning that as you get to higher and higher FiO2s, the pressure inside your lungs will be higher relative to the pressure in your chest wall. Or in the control arm, the higher your FiO2, they just titrated your PEEP based on this empirically generated table. There was absolutely no difference between the two arms. Interestingly, if you looked at what happened as soon as you enrolled, in most of the patients in both arms, you increased the PEEP. In a lot of the patients, the PEEP stayed the same. And in a small minority of patients in both groups, you had to decrease the PEEP. So my main takeaway from this slide is that we need to be more aggressive with our PEEP, because in both arms of the trial, as soon as you were enrolled, it turns out you were probably on inadequate PEEP. I have a couple really busy slides here. The only thing you need to know is that the two groups were almost exactly the same in every parameter. Their ventilator pressures, their PEEPs, their FiO2s, everything ended up being almost exactly the same. So there was no difference in outcomes between the two groups in terms of outcomes. Most parameters between the two groups were very similar. The interesting thing is if you look at the esophageal balloon group, about 12% of them received a PEEP greater than 24. And 24 is the maximum PEEP in the empiric group. So there were about 12% of patients where if you just followed the PEEP table, you would not be giving them enough PEEP to recreate their lungs. So my conclusions are that you all wasted your time in yesterday's esophageal balloon session. Just kidding, I still use them. The PEEP table from Oscillate correlates pretty closely with esophageal balloon-driven management. So my takeaway from this trial is not necessarily that esophageal balloons are good or bad, or we should all use them, or we should all abandon them. I think what this did, it was actually an in vivo validation of the Oscillate PEEP table. We put a bunch of esophageal balloons in people, we compared those results to this arbitrary PEEP table from the Oscillate trial, and it turns out this arbitrary made-up table is actually pretty physiologically accurate. So for most patients, we can just stick with that table and not mess around with the balloon. Some patients, about 12%, may do better with even higher PEEP than you think is reasonable. So my personal practice, especially after this paper, is I use an esophageal balloon whenever I need to assure myself that it's okay to go to those super high levels of PEEP. Because once you get to 24 of PEEP, your RTs start looking at you funny and everyone gets really uncomfortable. So especially larger patients who I think need esophageal balloons, I'll go ahead and throw one in, and it makes everyone feel a little more confident going to those super high PEEPs. But my takeaway from this is for the vast majority of patients, until you get to the upper end of that oscillate PEEP table, you're probably doing just as well following that PEEP table. So Mr. Smith is still getting worse. He's on that PEEP of 24. His P-to-F ratio is now 60. He's paralyzed, prone. He's on inhaled nitric. His daughter did a Google search and is now asking you about ECMO. Do you tell her, A, we should put him on ECMO, B, there is no definitive evidence that ECMO will help him, or C, all of the above? I love it. I love it. All right, only 4 people are doubters. Great, I'm preaching to the choir. All right, all of the above. So many of you have probably seen the EOLIA trial that was published about a month after this conference last year. It was supposed to be the definitive trial in VV ECMO for respiratory failure. It was meant to address a lot of the shortcomings of the previous Caesar trial. It randomized patients to ECMO versus standard of care, and it was stopped early by the Data Safety Monitoring Board for statistical futility, which generated no shortage of letters to the editor. So the patients all had severe ARDS. They were failing best conventional management, including proning, paralytics, etc. The median P to F ratio was 73, and the median PEEP at enrollment was 12. So again, back to our previous discussion of the EP vent trial, we're probably all being not nearly aggressive enough with our use of PEEP. Regardless, with a PEEP of 12, many of these patients went on ECMO. Now, why was this a statistically futile trial? If you look at their enrollment criteria, 22.5% of their patients weren't enrolled because they were already on ECMO at the time of screening. So there's 16% of these patients had such a hyperacute form of ARDS that the team couldn't wait for screening and enrollment, they just went straight to ECMO. 6.5% of the patients had combined heart-lung failure and went on to VA ECMO. So already you're taking a slightly skewed subgroup of the ECMO population. These are the folks who could survive long enough to wait for randomization. And then the bigger issue is once you did get randomized, because this was conducted in France, where ECMO has become more or less standard of care, they couldn't really refuse ECMO to patients who were failing. So 28% of their control arm ended up crossing over into the treatment arm, which I'm sure led to some heavy drinking among all of their statisticians. So if you look at the intention to treat analysis, the p-value just barely misses significance. There is about an 11% difference in mortality between the groups, but the p-value is 0.07 and does not hit that magic 0.05. If you look at treatment failure, in which failure is defined as either dying on ECMO or failing conventional management to the point you have to cross over to ECMO or dying, then there is actually a very significant advantage to early initiation of ECMO. So overall, there is an 11% reduction in mortality, absolute reduction in mortality, and a 23% reduction in treatment failure. Now, if you look at that 28% of patients who crossed over, they had a median SAT of 77% at the time they crossed over. Despite that, 43% of them still survived, which means that probably we did some good by crossing them over. It's really hard to say. There are some fantastic post hoc editorials about this if you want to have some light reading before bed. But what I take away from this is there is a benefit to ECMO. Waiting for a patient to fail resulted in much higher mortality in the crossover group than in the group that was initially randomized to ECMO. So we should probably be ECMOing early and often. A conclusive trial of ECMO would take 100 centers, somewhere between 9 and 17 years to complete, which means we will probably never get that trial. So the bottom line, if you ask me, is that we should optimize our patients and then put them on ECMO early if they're failing. So the year in review: reducing anesthetic gases will not prevent delirium. Dexmedetomidine overnight and a reduction of other sedatives may prevent delirium. Esophageal manometry is probably no better than a high PEEP table unless you just want some reassurance that a PEEP of 26 is okay. And ECMO probably improves outcomes in severe ARDS, but we may never get a definitive trial. So thanks a lot, and I'll take any questions.